Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Bayer.
Hello, and welcome to this program entitled Unlocking the Enigma of Low Back Pain, Zeroing in on Effective Treatment Options. My name is Chuck Vega. I'm a clinical professor of family medicine here at the University of California, Irvine, where I'm also an assistant dean in the medical school. And I'm really excited to be joined by Dr. Brad Furlong. And Brad, I'll let you introduce yourself and how back pain is important to you as an academician.
No, it's great to be here. Thanks for the opportunity. I'm really excited to talk about low back pain today. So I'm a postdoctoral fellow at Memorial University of Newfoundland in Canada. A lot of my research focuses on low back pain, non-specific low back pain particularly, and trying to address unhelpful beliefs or misconceptions that a lot of people across the world have about non-specific low back pain in hopes of trying to modify their beliefs and change their behaviors and hopefully improve downstream outcomes like pain and disability.
Great. I mean, that's such important work. Back pain is something I see every day in my clinic, and we'll get into a little bit of the epidemiology as well as diagnosis and management. It's going to be a short program, but it's going to be impactful. And I think to increase the impact, it's patient stories that really make a difference. And so we have one to start with, and just to understand how back pain can impact somebody's life. Please watch.
I love playing softball, American softball. Football was my favorite. American football was my favorite sport. And then when I couldn't play that any longer, I love playing flag football. But now I love watching it on television. I have a daughter that also loves playing. So she's picking up my legacy. So that's pretty cool. So I have had moments that I have had where I wake up in the morning and can't move, can't bend my body. I take medicine, of course, and I feel like nothing's wrong. But also what happens is I got to go back to sleep. And that's when it really kicks in. And this time it kind of kicks in. My lower back really hurts really, really bad just being able to lay flat. And when I lay flat, my body starts to ache and my lower body hurts really, really bad. And I'm asking myself, what just happened again? I go back to sleep. I take medicine to go back to sleep. And maybe I sleep through the night, maybe I don't. But for the most part, I go through the same thing over and over again in the morning until it kind of eases off eventually, but it takes a while. My daughter's in dance, so, I still think I got moves, but I can't move, but I don't have a back, right? And she notices it, and, when you can't, it drains you because you're like, I can't help my daughter, I'm defenseless, and being that you can't do anything, sometimes feel like you fail your kids, and that's a real thing. But I really no but is how can you get out of that? How do you get your mojo back? What's some of the things that you can figure out how to kind of contribute it, even though you can't move, is kind of what I've kind of put in perspective. It feels like you are, what's the word? Defenseless, right? And that pain is a level of pain, or you can't move. So, do you even wonder, is this going to happen stay for a long time? Like, you don't know if it's going to go anywhere. You don't believe yourself, like, listen, could I not walk again? Could I not move again? Sometimes pain gets to that level and you're asking yourself, is this ever? But you realize, like, it's not, or you have to psychologically believe that it's not, and then continuously to figure out how to do something to get motion or get moving. And that's what I think is the piece that I think really keeps you either engaged, or you're either not engaged and you're gonna sit and complain about the pain, or you're gonna find some way to get some movement going to get going. When I'm doing certain jobs and my back and is sporadically hurting, It's really, really challenging to, and if it's something I'm passionate about, it's really hard to do those type of jobs anymore because the pain just becomes random and you don't know when it's going to happen. And when it happens, when you're doing it, you feel that you that you're not valuable, and so you're just doing your day-to-day thing. You don't think of anything. You know the trash has to go, and you know I walk probably a pretty good distance to carry the trash out. And as you're doing it, you know, little things creep in that you realize, oh, okay, where'd that come from, kind of thing. But you know, you still have to do your day-to-day, whether it's mopping, whether it's taking the trash out, taking the recycling out. Um, work around the house, moving things, washing clothes, or whatever the scenario is. You have to still get it done. It's just you don't. It's not the game's turned off, and now your reality hits, and it's like when you're in that space, you kind of think, oh man, this is real, and so that's when everything comes to kind of hit you at one point at one time, and life starts. So that's what happens in my everyday life, you know. Sometimes just me and my daughter just taking a walk, and we're not walking far. We're walking down the street to the park. Before we could walk halfway to the park, it's like, hey, listen, I need to go back to the house. Why? My back is hurting, and like I would just love to take some medicine. But the reality is that medicine really gonna last long enough for me to enjoy my daughter and being able to put on a swing set or just see her go down the slide. Those are the things that really are what matters to me, and you know, I want to see something that's out there that can help me through that piece and being able to take care of my daughter.
I think this video was really important and that showed not just how low back pain can be severe, but the significant dysfunction and disability associated with low back pain that cuts across different domains of one's life, whether it's family time, social time, work or school. Everything can be affected, and oftentimes over time for years. I think one thing we'll come back to several times during this presentation is just how many cases are recurrent and relapsing. And so we always want to prep patients that low back pain is often a journey that lasts years. Brad, anything that you had in reaction to that video?
Yeah, I mean, you just can't really help but sympathize for the individual, and it's a very common story that you probably hear a lot in practice. And it shows not just that low back pain is, and I'm sure we'll get into those epidemiological statistics like you mentioned, but it has a lot of individual patient impacts too, social isolation, and not just that, but financial impacts and associated with early retirement. And you can see how that could be the case with a lot of people with low back pain. So and not just that, but also effects on the family of the individual with low back pain. They often need to take up caregiver roles and just a lot of things like that. So
Right.
yeah.
Right. And yeah, for my patients, I work in the biggest safety net clinic in Orange County. Low back pain, especially with their function at work, because so many are doing manual labor, it's a real killer in terms of their food security, their housing. It's a real problem, and so something we work on certainly together. And it is really common. 80% of U.S. adults are going to experience back pain at some point, and it is the highest cause of disability worldwide. And it affects low income countries, middle income countries, high income countries. Low back pain is incredibly prevalent, with a total of nearly 620 million cases reported in 2020, and that's going to increase as the population ages. And we know that age is one risk factor for chronic low back pain. We are going to see the number of patients come in. It's one of the most common reasons for physician visits overall. The peak age is around 85 years of age. And one thing that I think is important to note is that low back pain is more common in women versus men. In terms of thinking about pathology, inflammation is certainly implicated in cases of low back pain. But one thing I would point out is that chronic inflammation leads to neuromodulation, where patients become more susceptible to feeling back pain. So with neuroplasticity, chronic inflammation leads to changes in the way the brain responds to pain, so it becomes more sensitized to pain. So one of the goals of treatment, and oftentimes this is over a course of months and even years, is to reverse that process, to make the brain less sensitive, to those pain signals that are coming up from the low back. And it takes efforts in terms of exercise. It also can take efforts in terms of mind body medicine, which we'll get into a little bit as we go through this program. For me in my practice in primary care, most of the patients I see have non-specific low back pain. And indeed, that is how most patients present. And this is, we can't find a specific pathology, but it is a back strain after lifting a heavy box, after doing a really difficult day cleaning houses, or you just woke up, frankly, and your low back was really killing you that morning because apparently you slept on it wrong, is what my patients tell me. So that's 90 to 95% of cases are non-specific and fortunately have a better prognosis. But that means 5 to 10%. There is a certain pathology for herniated discs, spinal stenosis. Many times these types of pain are radicular in nature and that they're shooting down and producing sciatica. And so these are the patients who probably eventually get to imaging. That's how we make the diagnosis. But don't forget that not all low back pain is related to the spine. I mean, you could have GI processes, you could have pelvic floor pathology. You could even have pelvic organ disease as a cause of low back pain. So we want to keep our differential broad. We want to look out for red flags that could indicate a more serious diagnosis. And Brad's going to get into those in a minute or two. But I think one thing overall is that we want to do a better job of communicating how we're going to manage low back pain to our patients. And Brad's going to take, I'm putting a lot on you, but but you have a great presentation that really spoke to me, and that I was doing some of the things you're talking about, but not, I think not with the emphasis that you're going to bring to it. And there is a right way to take care of folks with back pain, emphasizing its chronicity, but also emphasizing positives and things that we can do, and trying to limit the sensibility that, well, I can't win. This pain's been going on for 6 months. It's only 15 or 30% better. So therefore it's going to be with me for life. That's not the way to approach it. And yeah, so we'll be getting into that as well. But I think it's a much better turn, and certainly better than ordering multiple imaging studies, ordering opioids, ordering treatments that we know to be ineffective, like bed rest. And yeah, that might actually be harmful for patients. Instead, we want to move forward. But it does start with evaluation and thinking about some of those symptoms or signs that could indicate a more sinister cause of low back pain. And Brad, I'll let you take it from here.
Perfect. Yeah. So, uh, when a patient, so I'll just remind everybody, I'm not a clinician myself, but I come from this from more of a public health and epidemiological standpoint. But I'm very familiar with the clinical practice guidelines and research treatments for low back pain. So, typically, when a patient comes to see you with low back pain, you'll do a patient history and a physical exam, as well as a neurological exam. So the things that you might be looking out for are red flags. And these can be things like signs or symptoms of infection, vertebral fracture, history of falls, things like that. Just because one of these red flags is present does not necessarily mean that the patient has, some sort of specific low back pain, some sort of condition under that umbrella, specific low back pain or lumbar radicular syndromes. And so this kind of a hot topic in research right now, where there's a few different groups kind of really digging into red flags and what each of them means and how accurate they are for predicting these various conditions. And so basically with the red flags, some guidance or some research suggests considering combinations of red flags, and of course together with the patient history and the clinical exam, things like that to come to a decision. But what I'd like to talk about mostly today are yellow flags. And there's something that is kind of not very commonly talked about with low back pain. There's kind of been a shift in thinking with low back pain over the last few decades, from approaching it more from a biomedical lens, really focusing in on those biophysical factors. But we're starting to really understand the importance of the yellow flags or psychosocial factors, and approaching low back pain management through a biopsychosocial lens rather than a biomedical one. And so there's a few different tools that have been developed to help assess these yellow flags. The Start Back tool is one, the Cerebromusculoskeletal Pain Questionnaire is another. And basically they ask questions not just about physical factors, but also psychosocial ones that we know have impacts on they can worsen outcomes or prolong recovery. And these are things like low or negative moods, beliefs. There's a whole bunch of unhelpful beliefs about low back pain that conflict with best available evidence. So the presence of beliefs like these and social factors like problems at work or poor job satisfaction, as well as even lifestyle factors. We know that smoking is a significant risk factor for low back pain, and obesity, for example, is another one. So, kind of assessing and addressing these psychosocial factors is pretty important for low back pain. So Start Back is just one example, and it's a 9-item questionnaire that assesses these factors. And the interesting or neat thing about it is it doesn't just assess factors, it kind of recommends stratified care based on the presence of these factors and the level of psychosocial or level of risk that somebody has for long-term disability based on the presence of these factors. And so what it does is it kind of stratifies care into low, medium, or high risk treatment pathways, where if the patient has low risk, you might provide them with simple education, encouragement for self management, advice, or reassurance. Where the medium and high risk pathways, they suggest providing patients with more dedicated care, like early referral to physiotherapy, with the high risk groups often being referred to PTs with special training in psychological therapies to address those um, psychological factors. The yellow flags are important to address, and they're a lot of what my research is about.
That's really good information, Brad. Thanks very much. And so I like the concept of these yellow flags, and I really like Start Back because it gives you, because you can say, well, okay, you're at risk for chronic disability and prolonged pain, but then what do you do with it? So sending somebody for mental health support could be an option too. It doesn't directly help pain, but it does help everything around the pain, helps patients manage pain, and it definitely improves on that disability side as well. So think about that kind of support for your patients. What you don't want to do is over image. So we used way too much imaging. So patients may request imaging. And when they do, I say, well, we can think about that. And really, the time when we think about that is when we're thinking of doing something invasive. So that means we're going to be doing some kind of injections around the spine, or we're thinking about surgery. And that usually is like, oh, well, I don't want to do that because I've only had this pain for 3 weeks. And I agree. I don't want to do that either. The other thing I tell patients, it's radiation that your body just doesn't need. And then finally, we can find a lot of incidentalomas in that lower abdomen and pelvis area that then we have to chase with further imaging. That's further worry for the patient, further expense, and further radiation exposure. So, really want to use imaging only for cases where, like I said, when we are thinking about doing something that's going to be more invasive, that's where we want to pull imaging in. But there, instead, what we should be doing is emphasizing some of these biopsychosocial and non pharmacologic treatments. That is a much better spend of our time. Brad, you want to take it from there?
Yeah, absolutely. So definitely more of a focus on biopsychosocial treatments. And the most commonly widely accepted treatment for low back pain is education. A favorable prognosis of low back pain. I'll get into more specifics in a little bit, but reassurance, advice to remain active, those are the most widely considered first line foundational treatments for any patient with non-specific low back pain. But most commonly, care is subdivided into recommendations for patients with acute pain and chronic pain right now in most clinical practice guidelines. And so the way it usually goes is, well, acute pain is referred to as patients with pain for less than 12 weeks. Chronic uh, is patients with pain for 12 or more weeks. And sometimes you have a group in the middle called the subacute phase, where that can last anywhere from 4 to 12 or 6 to 12 weeks, depending on who you ask. But that's thought of as more of like a transition period from acute to chronic pain, where most people's pain gets better within 4 to 6 weeks, and if it doesn't, then there might be some more emphasis on those psychosocial factors that need to be addressed, sort of thing. But with that out of the way that care for low back pain is really set up is that everybody should be getting education, acute and chronic low back pain patients. But if you have persistent pain, there's often more of an emphasis on the education plus things like the physical therapy, supervised exercise programs, as well as psychological therapies like CBT. Um, and just in general, there is a really big problem with low back pain where there's so many unhelpful beliefs and things like that. And we're, as a research community, we're trying to emphasize the importance of like the positive health concept, where just generally healthy behaviors are important. And reducing the focus on absence of disease or targeting a specific area that's causing pain, but just generally engaging in healthy behaviors and physical activity and things like that is really important. And just as an aside, there's a couple of um, really commonly used treatments that are used in practice, but guidelines actually recommend against them. These are transcutaneous electrical nerve stimulation and traction used all the time. And so part of my job as an implementation scientist as well is trying to address that. And I didn't know if you had any comments before I go into some pharmacological treatment options
Yeah,
on,
no. Well, pharmacologic is definitely something we use a lot of, and we should. It's a
yeah,
very good adjunctive therapy. But physical activity is key. I find what the patient likes to do, even simple walking, has been shown to be a help for low back pain. And it's the most popular form of exercise overall. So it kind of depends on what your patient has in front of them and what they like to do. Because I want one thing that won't work is if they do the exercise once a week. I don't think it's really going to be nearly as effective. So something they can do routinely, even if it's for like 20 minutes, 5 times a week, I'll take that because that's when I start to see some therapeutic effect.
yeah,
And you want
for
to make it
sure.
reasonable too, because some patients want to go right to the gym and strengthen their back after and do some exercise, which could be potentially harmful. So try to work with them on an exercise plan, and then you always have your physical therapist alongside to help guide that journey as well. But yeah, that said, pharmacology is very important here.
Yeah, yeah. And so perhaps probably the most commonly and widely accepted pharmacological treatment option are non-steroidal anti-inflammatory drugs. They're by and far the most recommended, consistently recommended throughout the different guidelines. And interestingly, though it's commonly used today still, acetaminophen or paracetamol is no longer recommended as a standalone pharmacological treatment option. There is a little bit of conflicting guidance over muscle relaxants. Some guidelines, I think, recommend them, some don't. But basically, I think you could say that for select patients, for selected um, reasons, muscle relaxants may provide short term relief for patients with acute low back pain. And like you said, corticosteroids, there's no recommendations, or the recommendations are against the use of corticosteroids. So,
Yeah, I would, and these are just guidelines. So if a patient comes, it's not that unusual. I can think of a couple patients who come to me and said, I had this a year ago. I used tens and acetaminophen and I got better in 3 weeks. I'm fine with that because why? I'm not worried about your safety at all. NSAIDs, among adolescents, there is a risk of gastritis and GI hemorrhage. And the more you use, the higher that risk goes. And so for many patients, if they're using for a few days, it's not, it's that risk is very, very small and outweighed by the benefit. But yeah, you have to treat the patient in front of you. But these are great guidelines, Brad. I totally agree. For me, taking out steroids, yeah, if we can just minimize the use of systemic corticosteroids. So thinking about pharmacotherapy, many times patients will self-treat with the medicine before they come see me because there's certainly a wide variety of analgesics available over the counter. We talked about acetaminophen. It really is not effective for low back pain, so I don't recommend it. Instead, I'm going to reach for an NSAID, ibuprofen, naproxen. Naproxen has the benefits of lasting a little bit longer, 8 to 12 hours versus the duration of effect of ibuprofen, 4 to 6 hours. Less frequent dosing can be very helpful for many patients who have difficult time breaking off midday to take an extra dose if they are having pain. Aspirin is a less used possibility, but certain patients, primarily older patients who grew up with aspirin, are more likely to use it. So I think that it still has some role, but if you're taking a baby aspirin daily because they have a history of cardiovascular disease, that's not going to help with pain. All of these have an onset of action in about 30 to 60 minutes. So that's something that I want to warn patients about, that it's not going to work within 10 or 15 minutes. And I do think about other types of NSAIDs, prescription NSAIDs as well. By the time they see me in clinic, many times patients do need a prescription NSAID that helps patients to function, whether they're in their work role or family role. Many times they have to be active for over 12 hours a day. And so those can be helpful if they need that. But if patients are calling in or putting in a portal message like, hey, what can I take OTC? You have your ibuprofen, naproxen. Those are my go-tos. So once a day is better than twice a day is better than 3 times a day. I personally try to use, because many of my patients are working and they are experiencing that pain, which in really hurts their function across multiple roles. So they go to work and they need relief, but then they come home and take care of kids and they need relief. But Brad, any comments on on pharmacotherapy and maybe the way patients view it and other things they might want, but besides wanting to get relief now, wanting relief to last a long time?
Yeah, yeah, no. I mean, I totally understand that they're just guidelines, and as clinicians, you have to be pragmatic and come to a shared decision with the patient based on their preferences and things like that. I don't know too much about pharmacology and things like that myself, just epidemiologically and the stats behind them. But no, I absolutely agree with you on what you said.
Cool. Well, so let's return to education then, because that's something, how we'll talk about how we can apply this in a busy clinical setting.
Yeah, yeah. So I kind of just wanted to talk very briefly on why education for low back pain. And I mean, I think some people might be a little bit surprised on how emphasized it is as a treatment for low back pain. Because many people think it doesn't really do much, and I know from my research experience there are clinical trials that um, assign inactive control groups education, and I just find that really interesting because it's proven, or not proven, but it's shown to have small positive impacts, education alone, on improving clinical outcomes like pain and disability. But I just wanted to give a little backstory that the reason, or the theory behind it, is that we know from substantial amounts of evidence that people all across the world have lack knowledge and have unhelpful beliefs or misconceptions about low back pain. Basically, these are things that just conflict with best available evidence. And we know that they're associated with worse outcomes. So, some beliefs, or some examples of them, are that are very, very prevalent, are that low back pain has a poor prognosis for everybody, that it has inevitable and unavoidable negative consequences. I mean, go back to that the patient interview, they were afraid, or they had fear avoidance beliefs that they might never be able to move again. And not making any assumptions based on this short video, but it's just a common uh, belief in the patient population. Other things, that like pain equals damage, that because you have pain, you have structural damage, and that you have a weak or fragile spine that needs to be protected. So things like that. And these are associated with worse outcomes. And the thought is that education can be provided to patients to increase their knowledge, modify these unhelpful beliefs that conflict with best available evidence, and hopefully improve downstream clinical outcomes like pain and disability. And on the other side of it, we know that patients themselves frequently report wanting, they recognize that they're missing information, that they're lacking knowledge about low back pain. There's a systematic review by Dr. Lim and colleagues in 2019 that showed this, and that patients consistently report wanting consistent, credible information about low back pain, but they're just not getting it in practice. And if they are, they often report receiving conflicting information from provider to provider as well. And so a lot of my research is trying to address this issue, trying to figure out ways to provide education in practice, because I understand that clinicians don't have 20 or 30 minutes for every patient to go over every single possible thing about low back pain. And so we're researching education materials as kind of like a standardized evidence-based supplement that can be provided to patients. And we did a comprehensive assessment on many education materials and found that the My Back Pain website by Dr. Paul Hodges Group in Australia is perhaps the best available patient education material right now that clinicians can provide to patients in practice. And then I have a little bit on, how to talk to patients about low back pain. I don't know if you just had any other comments before I get into that.
No, I looked at the Mind Back Pain site. Yes, it looks very helpful, very easy to digest videos. Nothing is too long. It's kind of fits our current attention span as a society. So I think, and it all seems very, very valid information for sure.
Yeah, great. Yeah, awesome. So, so as part of these assessments of educational content, we quickly realized that there's kind of no resource telling anybody what to actually tell patients about low back pain. And I mean, you're probably familiar with the guidelines. They all say to provide education, vast majority of them. But the most you kind of get from the guidelines is maybe the nice UK guidelines are perhaps the most informative, but not really. They kind of just tell you to provide education, advice to stay active, and reassurance of the patient's favorable prognosis. But other than that, the guidelines don't really specify what to tell patients. And so we developed a checklist to assess if patient education materials contain information that patients have said they want to know about low back pain and that experts believe patients should know about low back pain. And basically, it outlines 21 different information needs that are potentially important things to kind of convey to patients. I will say it's brand new, it's preliminary in nature, but it probably is one of the most comprehensive resources on this topic to date. It just there's a whole lot more work to be done, basically. But if you're thinking about kind of what things that you can talk to patients about with their low back pain, the kind of key points are to recommend to stay active, which basically just means keep up with your usual activities. If you go to work, you might want to keep going to work. If you go for a walk, like you suggested, twice a week, you might want to keep up with going for a walk. To avoid bed rest, and that movement is safe even with pain. Also, that low back pain has a favorable prognosis for the vast majority of people. Most people get better from their acute episode of low back pain within a few weeks, even without treatment. Also, that imaging is not needed to diagnose low back pain. It can't diagnose not specific low back pain like we previously discussed. And even if the patient gets imaging, it really doesn't inform future management options. Like you were saying, imaging is often more helpful for informing more invasive procedures down the line, for example. Not always, but also that hurt does not equal harm. Hurt does not equal harm. Pain does not equal damage. If you have pain, it does not mean that you have structural damage or anything in your spine. And also, you could just discuss and acknowledge the influence of psychosocial factors, and recognizing low back pain not as a disease caused by a biophysical factor, but a complex symptom influenced by biophysical, psychological, social, and lifestyle factors, basically.
Well, I definitely will attribute this to you. The line that when you're trying to bring patients more onto that positive side, of proactive side, that we can do something about your low back pain, telling them that your back is one of the strongest structures of the body. I got that from you, and I'm going to use it. So it really helps that and because we've all had the patient come to us with an outside MRI and says like, see, there's a 2 millimeter disc protrusion here and a 1 millimeter disc protrusion, and they're like, it's always highlighted and like kind of circled. And it's like, wow, we have to fix this. And like, no, we absolutely don't need to fix that. Fixing that would be the worst thing that you could try to do. Instead, let's work together and use multimodal therapy, which I'm very quick to enact for these patients. So get the physical therapist involved. If they need it, get mental health support involved. Get websites like My Back Pain involved, so they feel empowered to do more on their own. And then guide them on that journey. Employ the pharmacotherapy. And those cases, an initial presentation will do better within a course of months. So I reassure them of that as well. That strong back will come back, and you will be able to. We will get you better. One of my favorite lines, I just used it with my last patient yesterday, was, "I think you're going to get better. I just want to see how much." It was not low back pain, but it definitely applies here. When I see you again, I know you're going to be better. It's just a question of how much better. So I try to give them some message of hope when I'm leaving. Speaking of message of hope, Brad, any final thoughts before we close this session?
I think I'll just reiterate the shift in thinking from biomedical to biopsychosocial and really assessing and addressing those yellow flags. I think really is the key forward for low back pain treatment. And the current thinking, and especially from me, because it's what most of my research focuses on, is I think we can address these things through education. And it's mostly through just a matter of how we can kind of get education implemented in practice. Those are kind of the next future questions. So, any key takeaways for you?
Oh no, I think I just stated them, and so I thought this was a wonderful synopsis. Some of the people who are watching this program are experiencing low back pain currently themselves, so hopefully you'll feel heartened with the information as well. So Dr. Furlong, it was outstanding. Thank you for all your hard work in this important subject, and thank you for this presentation. Thank you all for participating in this Medscape activity as well. Hopefully you found it helpful and relevant to your practice. You can find some useful tools and resources on the right hand of this page, and we hope to see you again soon in another activity. Take care, everyone.